Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. It is now my pleasure to introduce today's first presenter, AHA moderator, Mindy Hatton.
Thank you, and thank you for joining us today. My name is Mindy Hatton, and I'm the General Counsel at the American Hospital Association. I'm also the Executive Liaison to our Hospital Against Violence Initiative, or HAV. I'm also joined today by my colleague, Ashley Hoffman. Ashley is a Program Manager with our Center for Health Innovation, and she currently supports our Population Health Teamwork. Today's webinar is brought to you by our Hospital Against Violence Initiative, which focuses on combating community violence as well as violence in the workplace and against our precious workforce. This webinar is the second in a series on supporting victims of mass violence and the communities they live in. It was developed in partnership with the National Mass Violence Victimization Resource Center. Today's webinar sets the stage for better understanding how hospitals and health systems have heroically responded to incidents of mass violence and the type of planning that hospitals and health systems could and should do to prepare for future incidents. To help us achieve those goals, we are delighted to welcome today's speakers. Following their presentations, we'll have a short Q&A session. But we couldn't have two better speakers for this topic. Both systems responded heroically to one of the nation's worst incidents of mass violence in Las Vegas on October 1st, 2017. We'll begin with Mason Van Houweling, who will turn afterwards to Todd Schlamberg, who will be our second speaker. Mason Van Houweling serves as the Chief Executive Officer of University Medical Center. He provides leadership to a diverse team of 4,000 employees who dedicate their career to delivering Nevada's highest level of care. He guides Nevada's most respected academic medical center and supports the strategic vision that the organization uses in order to save lives and improve the lives of the community it serves and those who live in the communities. He's joined by Todd Schlamberg, who is the Chief Executive Officer of Sunrise Hospital and Medical Center. That's Nevada's largest acute facility at 690 beds. He also is the Chief Executive Officer of Sunrise Children's Hospital, which is located on the same campus. Prior to taking this position, Todd served as Vice President at St. Louis Children's Hospital. Please join me in welcoming our speakers. Mason, I'm going to turn this over to you. Thank you.
Thank you very much for the introductions, and it's a pleasure to speak to all of you today in regarding the topic and the events that happened on October 1st, 2017 in Las Vegas. A little bit about University Medical Center. We have been in the community since 1931. We're affiliated, we're a teaching hospital with the University of Nevada School of Las Vegas, School of Medicine. We're about 4,000 strong as far as our employees, 1,000 physicians that are on staff, 1,200 nurses, and we're licensed for 541 beds. In particular, I'm going to be speaking mostly around our trauma center, and we've got a unique trauma center, and you can see the picture of our trauma center on this particular slide. We are the only freestanding trauma center west of the Mississippi. It's a standalone contained building. We serve about 12,000 patients annually. In our trauma center, we have 11 resuscitation beds. We have an 18-bed ICU. We also have 3 surgery suites and a full PACU. And very proud to boast that our survival rate is 97% survival rate, and some of those patients had a less than 1% chance of surviving. Just a little kind of a map in regards to our proximity, and you'll also see Sunrise, who's actually closer to this particular scene. The event happened on at the Mandalay Bay on the 32nd floor of the Mandalay Bay, and right across you've got Las Vegas Boulevard to the right. As you can see, the Route 91 fairgrounds there. And then very close to the Mandalay Bay is our kind of our main corridor, our main highway, which is Interstate 15. And we're approximately about 6 miles during daytime traffic, about 23 minutes away. Just to kind of set up that particular night, on September 25th, a gunman checks into the Mandalay Bay, eventually occupying the 32nd floor with, again, a direct view of the festival grounds. He was there for many days, ultimately bringing in over 24 guns, mostly AR-15s with altered stocks, with bump stocks. Also had vertical foregrips, but mainly containing high-capacity round magazines, minimum 40, some upwards to 100 magazines capacity. Also found in the room were surveillance cameras, many cell phones, scuba equipment, baby monitors for surveilling the property, but also the room. Through that week, October 1st, which was a Sunday, around 9:40 p.m., there was about 22,000 people in attendance. The closing act, which was Jason Aldean, took the stage. About 9:59, there was a kind of a altercation, or at least some investigation from one of the Mandalay security guards. Paddock was made aware, based off those surveillance cameras, he was actually investigating the room. And then Paddock approximately fires 200 bullets through the walls and the door at the hotel security guard. He was actually wounded, but is actually doing very well today. So we're glad he survived. Very quickly after that, the gunman proceeded to fire thousands of rounds on concert goers from his suite, firing about 1,100 rounds with multiple weapons that I described in about a 10-minute period. At 10:25, UMC receives its first victim, and both Todd and I will talk about the kind of the unconventional way that people arrived. Initially, UMC was notified that there was an active shooter on the Strip. Both our night and day teams were still here in regards to our trauma center, and we were officially initially notified that it would be 5 to 10 patients from the scene and expected to arrive at UMC. At that point, we had called our backup surgeon and our anesthesiologist, and then we very quickly received a second notification that to really expect 50 to 100 patients. At that point, we have activated our disaster plan and very quickly started to place gurneys and IV bags in the hallways and outside our trauma center to prepare for the influx of patients. So, as you can see here in this picture, many of the team was waiting for patients to come in, and as I mentioned, they came in very unconventionally. Actually, our first patient that came in was a young female, carried in by two gentlemen from the back of a pickup truck. So in a span of just 5 minutes, UMC received 40 patients, and again, many of those were self-transported via cars, Ubers, taxis, and any way that anybody could get them to both of our hospitals. So I'm just going to talk a little bit about UMC's response and how we responded to the incident. Just a little bit about our campus. As you can see here, this is our campus. We're very close to the I-15 corridor. We have it's a 26-acre campus. We have our trauma building that is kind of on the north side of this picture. We also have an adult emergency department that is 60 beds, 59 beds, I'm sorry. And then what ended up becoming really, we have a children's emergency department, and unfortunately there were some younger folks there around 17, 16 years old that we did see. And then what ended up becoming really our fourth emergency department at UMC, we converted our PACUs in our ambulatory surgery units into emergency department overflows. Just a little bit about our operating rooms. We have 20 operating rooms in our main OR, that's not in our trauma. And then also we have a host of endo and procedural suites. So that night on October 1st was an extremely busy night already. We had 9 of our trauma beds of the 11 beds that were already occupied. So once we received that notification, we quickly, as you can see in this picture, lined up beds to be able to receive and overflow those patients. We also moved those patients that were in those resuscitation beds into other areas of the trauma PACU, but also into the ambulatory surgery area because they had been stabilized to be able to prepare for the influx of patients coming in. So I think, and I think Todd would agree, the timing of this incident, many of us were still awake at that hour. So, and many of our staff in our community was still awake at the hour. So things as far as communication happened very quickly. I think any other time in the evening, whether it's 2 or 3 in the morning, it would have been much more difficult to reach people because they perhaps were sleeping or preparing for the next day. But many of us were still awake in communication, text messages. The media was on it very quickly. So I know Todd experienced this as well, but we had really hundreds of our staff show up in droves, both physicians, nurses, all of our medical professionals, our EVS staff, our food, nutrition staff really showed up without having to be called because they knew that this was a major event. So that really helped with the response. People showed up immediately without being having to be notified to come in. So that was very helpful. It was really all hands on deck and everybody working together. I think also we, with the trauma surgeons that we had in house at the time, as you can see, I had 2 trauma surgeons in-house, but we also, because we have 217 residents and fellows, we're able to lean on that cadre of surgery, orthopedic, and emergency medicine residents that were already in the building. And then within 30 minutes, we notified our backup team, adding 2 more trauma surgeons and 2 more fellows, making that total of 6. And then in addition to all the residents. And then within 1 hour, another trauma surgeon came in, 2 more fellows, and then within 2 hours, having a total of 8 trauma surgeons and 4 fellows really helped as far as performing those surgeries in a very quick manner. You know, I think if I could recommend to everyone, I think people in that moment want to all come in and help, and you have a lot of reserves and backup teams, but we knew very quickly that this was going to be a very long event for us, that this was going to take days and days. And so as much as you feel the urge to call in everybody at that moment, just being mindful that you have to have fresh reserves and a fresh team to come in and care for those patients the next day. And so we were very mindful of that to make sure that the existing staff that had worked the hours and stayed for hours beyond their shift, that they were able to get relieved with a fresh team, and they were sent home to be able to come back over the next couple of days. You know, we worked very well with our internal medicine, our family medicine teams to help move patients around the facility and get them in other parts of the hospital that they normally would not be cared for. And then just making sure the second shift coming in and doing all the documentation that when you're expediting care like this, making sure that we're able to make sure all the documentation was detailed and completed for the staff. So overall stats for UMC, we received 104 patients. We did more than 20 surgeries on 12 critical patients within the first 24 hours. Of those 104, 60 patients were ultimately admitted. Many of those patients were treated and released within the first 24 hours. We did receive other patients from other hospitals that evening, and then we administered 70 units of blood, and you can see the details of those. And then we did have 3 fatalities that unfortunately passed away en route, but very proud to say that no one who arrived alive died at UMC. Just some of our key advantages. I think, as you saw, we had a pretty deep bench of trauma surgeons. We have a wide specialty, being a level 1 trauma center. In this picture, these are some of our trauma surgeons that evening and over the next couple of days. And the taller gentleman is Colonel Colonel Pietsak, and what he was able to do, he's actually an Air Force trauma surgeon, and we have a relationship with the Air Force Base, and we have rotators that come through, trauma surgeons, trauma nurses, technicians, radiology techs. So they were instrumental, and a lot of Air Force medics saved a lot of lives that evening. So I'm very thankful for our relationship with the Air Force. Some of the unsung heroes, the anesthesiologists, we definitely couldn't have moved things around and opened up the operating rooms that we were able to do so quickly, and they were great to be able to, so making sure that they're always involved and part of the team. And then the 70 surgery residents and fellows that we had that night was extremely helpful. I just think kind of wrapping up some of our lessons, and we'll be turning it over to Todd here shortly. I think just realizing your resources you have, having the incident command system. We drill frequently with our partners at Sunrise throughout the county, through our airports and other agencies here, but you can never do that enough, and doing that at all hours, because we know incidents like these don't happen Monday through Friday, 9 to 5. So ensuring that your on-site leadership is aware on what to do, and that they're drilled frequently as far as some of the urgencies and the emergencies that happen is extremely important. I think mobilizing all your physicians, nurses, your lab, your blood and pharmaceutical supplies is extremely important. I think we also were prepared. A lot of folks were in town, and a lot of physicians and nurses, so we were prepared for emergency credentialing, but fortunately we did not need to do that, but we had many people show up ready to help, but we put them in other ways to help at the organization. So, I think some of the other things are to make sure that taking care of the well-being of your staff. We knew that people were seeing things that were very traumatic, so we engaged our behavioral health, our nurses, our psychiatrists to be able to, in some of our pastoral care, to be able to support both hospitals. Media shows up in droves, so you've got to be prepared from a public relations standpoint. We had not only local media, state media, but also national and international, and I'll tell you, within literally 2 to 3 hours, California media was here on our doorstep. So that lasted for about a week to 10 days. I think what really took me back is just the overwhelming level of support from our community for both hospitals. I think almost immediately after the incident, both hospitals started receiving huge amounts of donations, food, water, comfort item for those patients and families. So mobilizing your team to be able to be prepared and how to store that and make sure nothing goes to waste, and that donor intent is always followed. And then also, I think because there were so many victims and so many wounded, both hospitals had hundreds of community members that lined outside our doors in our blood services to really want to give blood. So that's something that I would highly recommend, ensuring that you're ready for that type of support. We actually spent time with Orlando Regional Medical Center, just getting briefings with them prior to this event ever happening, and that's one of the things that we learned was the community support. So it definitely is overwhelming, and it's very greatly appreciated. And this is our team, and again, afterwards, you've got to keep morale up. And while we saw the worst tragedy event happen in our history in Las Vegas, Todd and I would both agree that we saw the best come out of our staff and our community. So this is Team UMC, and just very grateful for everything that they've done for our community. So with that, I am going to, it's my honor to pass the presentation on to my friend and colleague, to Todd Sklamberg, CEO of Sunrise Hospital.
Well, thank you so much, Mason, and appreciate your comments. And many of my slides, share some of the same sentiment as Mason shared in his. And I think, as we reflect back on this incident, the collaboration between Sunrise Hospital, UMC, and an entire hospital community here in Las Vegas and we have a total of 14 acute care hospitals in Las Vegas, allowed us to work through this very, very challenging situation. A little bit about Sunrise Hospital. We are 762 beds, which is inclusive of our adult and children's hospital. We see about 170,000 patients coming through our emergency rooms, as well as we are a level 2 trauma center, although our capabilities are equivalent to a level 1 clinically. As Mason referenced, we are both in pretty close proximity to the event. Sunrise Hospital is about 5 miles, and as Mason shared in his presentation, UMC is about 6 miles. And the yellow portion here is Las Vegas Boulevard or the Strip. And as Mason referenced, when the shootings occurred, the mode of arrival varied pretty significantly. I think, as Mason referenced, many of our victims were transported to the hospital by Uber and Lyft and taxis, the police department, and I recall actually a pickup truck came by with 4 patients in the back, and actually one individual broke into a pickup truck, hot-wired it, and drove some of the victims to the hospital. Often the private vehicles or Uber were actually following the ambulances and fire department as they made the way to our 2 facilities. A little bit about the number of patients and some of the statistics, and I'll go through over the next slides, a little of the data. And probably before that, let me just back up to that evening. And as Mason referenced, I think it is very fortunate, if there was a silver lining in any of this, that this event occurred on a Sunday evening. If it was a Friday or Saturday night, many of our staff, colleagues, and communities may have been out to dinner, may have been elsewhere and not easy to access. Preparing for work and school, and being home Sunday night, I think was an advantage for our entire community on how we responded. And it was a little bit after 10, and any trauma page I actually get on my phone. And it was around 10, and a message came across my phone that fire department declares mass casualty. And when I saw that, I first called in to our house supervisor asking, hey, do you know what's going on? And the house supervisor, was not aware, and then got a second page, stating the same thing, and decided to drive down to the hospital. And similar to Mason, we live about 20 minutes away, and as I was driving down, I saw in each intersection, going from the south to the north, police car after police car heading down to the north side. So I knew it was something pretty significant. And what we ended up seeing at Sunrise was a total of a little more than 240 patients who came in. 212 we were able to identify, and actually we treated 30 patients and released them without obtaining any information. What turned out to be a challenge is 92 patients of the 212 who arrived at the hospital arrived with no identification. And, as Mason referenced and laid out early on, an outdoor concert, you hear, some shots. When you determine what's going on and scramble, many of the women lost their purses. Many of the men actually lost their wallets and identification during their scramble to safety. So we had 92 patients who arrived with no identification, and I'll talk a little bit about a little more about that here in a couple of minutes. We had 64 immediate admissions, 31 directly to the ICUs, and the outpouring from the community was very significant as Mason referenced, to both our hospitals as well as the other 12 hospitals in our community. We performed 83 surgeries within the first 24 hours, and a couple of the other statistics are here. Of the 212 patients that we treated, 124 were gunshot victims. Have a breakdown for you of the surgeries in the first 24 hours and the type of surgeries, and then 83 total surgeries within that 24-hour period. We had a total of 16 mortalities, and very similar to UMC's experience, as Mason shared, we had 10 patients who arrived at the facility who were DOA. 4 came in unsalvageable. We had 1 who was brain dead. He was from Arizona, and we kept him alive until his parents were able to get to the facility. And then 1 intraoperative death, which that patient had her aorta basically blown apart, was in surgery for 7 hours, and unfortunately that was the 1 fatality within the hospital. And very similar to Mason, our survival rate was 99.5%. We had 516 blood products that were utilized and really leveraged all of our hospitals in town to acquire the blood, and very proud of the 516 blood products that were administered. We had no adverse events from any of the transfusions. Quick timeline of the event, and at that time, very similar to Mason's experience and UMC's experience, we were full. Our hospitals were full. Our ED had over 100 patients when that first patient arrived. We peaked at about 228 patients in our emergency room around 3 o'clock in the morning, and really relied on the entire hospital to help clear out some of our spaces for patients that were arriving. And between midnight and 5 a.m., we were actually able to discharge 167 patients from our hospital successfully. And when we look back retrospectively on any readmission rates, they were not any higher than what our community typically sees. So kudos to the entire team. At a time of crisis, it's amazing how quickly we are able to mobilize resources and work on throughput. I cannot, in a 24-hour period of time, even at 11 o'clock at night, really can't get to 167 discharges. So at times of crisis, we're able to really pull out all of the stops. If you went into our emergency room at 11 o'clock on October 2nd, it would be hard to believe that we had such an event. We were able to clear everybody out of the emergency room and at least resume our ER to somewhat normal operations. And then we cleared our internal disaster later that day. One of the successes on how we responded is we set up a dual triage process where patients who were coming into the emergency room, we initially triaged immediately in the main lobby. We utilized our trauma bays for the sole purpose of monitoring the ABCs, airway, breathing, and circulation. In essence, the trauma bays and our ER was used to stabilize patients, immediately. If chest tubes were needed, they were placed. If the patient needed to be intubated, they were placed. There was really no other triage done in that space. We then identified other areas in the hospital and cohorted patients with similar injuries in those areas. We were able to clear out most of our neurosurgical ICU, our trauma ICU, medical ICU, and cardiovascular ICU by doubling and tripling patients in the units. And we cohorted all the gunshots to the chest in the cardiovascular ICU, all the gunshots to the head in our neuro ICU, gunshots to the chest in our trauma ICU, and orthopedic injuries. We used our recovery room to cohort those patients. By doing that, as our neurosurgeons arrived, and we had about 7 neurosurgeons that arrived within an hour, they were able to head up to the neurosurgical ICU where they had all of their head wound patients in one area to more effectively allow them to triage like type of patients rather than trying to locate patients in the emergency room. And the same thing as the cardiovascular and cardiothoracic surgeons came in. All the gunshots to the chest were isolated in one particular area. We dispatched anesthesiologists to each of those areas to help coordinate use of the operating room and triage patients, accordingly. When we look at the logistics, being able to obtain blood from other hospitals in town was absolutely beneficial, and we created mini supply rooms actually right in front of our trauma bays, where a respiratory therapist created a kit with a chest tube, intubation materials, all in one bag. So as patients came in, the critical care team was handed a bag, and they were able to have chest tubes and intubation materials, immediately available. As Mason referenced, as the events, continued, providing support for our staff was absolutely critical, and we were very fortunate with the help of the VA, local teams, and crisis counselors that we're able to bring in to help our staff, cope with what they saw, as well as providing those resources to the patient. There's probably one other point I do need to mention. As I mentioned earlier in the presentation, 92 of those patients came in without identification. One of the first things we did was first cohort all the family members in the auditorium. And I went into the auditorium about every 30 minutes, to address the families. And I recall walking down to the auditorium the first time, thinking to myself, what do you say? What do you say to, there were probably about 300 family members in the auditorium who, number one, did not know if their loved ones were at the facility. Many of them were from outside Las Vegas, and went in there and at least shared a little bit about Sunrise Hospital, and at least shared some words of hope, and to let them know what was going on. With the 92 patients who had no identification, we actually went through a process, and it took between 4 and 6 hours. We had several of our managers go through the entire hospital for those patients who did not have identification, and actually wrote down identifying marks and descriptions of all the patients. We then met with all the family members, and the family members shared identification and pictures of their loved ones. However, if you look on your phone and have pictures of a loved one, it's usually in a pose of happiness or vacation, and everybody looking their finest, rather than having gunshots and having surgical repair. So the most important identifying marks that helped us match up all the patients to their loved ones were piercings and tattoos. And we had descriptions from the patients and from their loved ones, and had a team sitting in our boardroom matching it up, and we're able to identify all of our patients. actually all 14 decedents, unfortunately, did not have any identification, and learned that one of the decedents was an off-duty police officer who had previously served as the community police officer for Sunrise Hospital. So really, really hit home. When we looked at what worked well and some lessons learned, I agree with all of what Mason shared. The importance of emergency training and emergency preparation. And from a hospital leadership standpoint, just reinforced the need to invest not just time but resources for always being prepared. Mason and I, given New Year's Eve, have taken care of lots of patients. Our ERs, at times on New Year's could see 500, 600, 700 patients, during those events. So we're able to handle, large, volumes. With the influx of nursing staff, we're able to provide every patient in our emergency room with one-on-one nursing care. We're able to mobilize all of our medical staff. The family and decedent management was absolutely critical, and the importance of drilling on how to effectively run an incident command center. I can't emphasize the importance. Other lessons learned, the need and having means of communicating with your medical staff, especially when the cell towers go down or are overloaded. Looking at documentation templates for MCI, our first responders actually, given the extent of the injuries, did not have sufficient documentation. So when patients came in, we were actually doing it the old-fashioned way. For any of those clinicians on the phone, of taking a Sharpie and writing the patient's vital signs on their forehead, their arm, other parts of of the body. So some lessons learned there, and we had significant debriefs with our county, with our state. Both Mason and I hosted local, national, and international emergency command folks from other cities, municipalities, organizations to share the lessons learned. And this event, as Mason also shared, demonstrated the ability of this community to pull together, the medical community to pull together, the resources pull together to provide the support to our communities, not just short term, but also long term. Just wanted to thank everybody for the opportunity for us to share our experiences, and I think we'll now turn it over for some questions and answers.
Well, thank you so much, Mason and Todd, and congratulations to both of you on the amazing job your organizations did to respond to this mass shooting, and for all the details that you shared with us, including the extraordinary survival rate for patients who made it to the hospital thanks to quick thinking and well-organized efforts, and also the innovative ways you used to identify patients who came to the hospital without identification using piercings and tattoos. Ashley and I wanted to ask you a few questions, follow-up questions, before we let you go today. And the first is, Mason mentioned that you had done some training together prior to this event in anticipation of some kind of event where there would be an influx of patients. And I wondered if the two of you could talk a little bit more about what kind of training you think, what kind of training you did and was most valuable, and that you would recommend that other hospitals, particularly those in urban areas, do prior to any kind of event where you're going to see a lot of an influx of patients who've experienced severe trauma. So, Mason, why don't I ask you to start? Thank you.
Sure, great question. And yeah, we are a very tight community, especially in our emergency response teams. So the Hospital Association, the Southern Nevada hospitals in particular, we drill frequently with our other agencies, whether it be on the federal, state, or local level, and we're fortunate to have an Air Force base here as well, Nellis Air Force Base. But we'll often do tabletop exercises. We'll do simulated exercises, whether it's an airliner accident or chemical exposures or mass casualty, or you can name multiple train accidents. We're fortunate here in Las Vegas not to deal with hurricanes and earthquakes and other things alike, but we do look at those type of events. So we've got a very good area command that coordinates a lot of that and brings all of our agencies together. But also hospitals will do their individual tabletop drills, but also Joint Commission. But we're doing far beyond the minimum requirements. And I think that was an advantage for both organizations that evening, that the incident command system worked really well. I can't tell you, constantly drill that, make sure your people are educated, that you've got backups, because that really is the central hub for the team to be able to conduct regular briefings, disseminate up-to-date information across all the departments, but also being a source of information for those area commands. And in this particular event was managed by our sheriff and metro officers, but they were constantly looking for information to be able to help mobilize resources, identify victims. As Todd mentioned, it was very difficult that evening, and then just manage the flow of information, help reunite families, both organizations, because were a lot of people from out of town. The call volume coming into the hospitals just was really overwhelming, and then just managing a lot of the media outlets, but always protecting patient privacy. But I'll let Todd chime in as well.
Yeah, no, Mason, I think you hit the key points, and a portion of this. Mason and I spoke multiple times during the course of 1 October, the actual day, then going in the next couple of days. It's also the coordination between our facilities, and we're part of HCA Healthcare, so have 2 other facilities here in town. Leverage those facilities to provide those resources. Work with other systems. To provide resources as needed. As Mason referenced, our county does a very nice job of drilling. So in addition to the tabletop exercises, several times a year we have formal drills that are run by the area command, where we actually receive patients, usually high school students who are mobilized up to simulate various injuries, and actually go through the process. And one piece to emphasize: when we drill, it is so important to drill as it is the real thing. It is very easy to say, well, if I had this type of patient, this is what I would do. Actually doing it really makes a world of difference in the level of preparation.
Let me ask one more question, and then I'll turn it over to my colleague Ashley. Mason, you mentioned that you reached out to Orlando Regional Medical Center, which of course previously had been a site of mass violence, mass shooting, maybe the worst before the Las Vegas incident. Was there any piece of advice or several pieces of advice that you got from them that you thought was particularly valuable that you'd like to share with others?
Yeah, I think, as we know, prior to the October 1st tragedy, the Pulse nightclub shooting there in Orlando was a significant event, and I think that really started the conversation with us here and in our community and the hospitals to start looking a little closer to that. And we actually had the opportunity to receive a briefing on how to truly be prepared from Dr. Gary Parish, and kind of ironically, that's where I started my career at Orlando Regional Medical Center many years ago as an admitting representative, and he happened to be in town, and our trauma surgeons had coordinated some training, and I was in the audience just listening and just really listening very closely on, okay, how much blood do we really have on hand? There's particular pharmaceuticals that to deal with shrapnel and pain management, but also infections, and so it was really a good training for us that was supposed to last an hour and a half, and probably went for about 3 hours. And it's just everybody really was collaborative, and just learning the lessons from Orlando Regional and the hospitals there on mass casualty preparedness. So it was really fresh in our minds, and so it really got us thinking. And I think our commitment, both Todd and I, is to continue to pass on these lessons learned, because I think after that event and in some of the training, it's not a matter of if or when. It's going to be a matter of when. So I think that's where we can constantly try to prepare, but sharing the collaboration and the lessons learned, really feel like it's our obligation to do that. So it's been an honor to be able to share that with Todd. And like he said, they've got an amazing facility, did a great job. Our community did a great job that evening.
Great, thank you. Ashley, let me turn it over to you for a question.
Yeah, thanks, Mindy. And thanks, Mason and Todd. Your story, it really shows the enormity of the situation faced by the Las Vegas community and by any community that's experiencing a mass violence incident. Can you tell us a little bit more about partnerships between your hospitals and various community organizations, either that were essential to your response or that have been formed in the years since the shooting, and how have these partnerships kind of transformed how you prepare for and respond to mass violence incidents and the resulting trauma? And then also thinking that these can be partnerships within Las Vegas or even in the hometowns of the patients, because you mentioned a lot of them were from out of state.
No, thank you. Let me take a stab at it, and first probably focus on, if I can, our teams. And as Mason articulated in his presentation, once we all got through the first 24 hours of the event and at least had the situation somewhat stabilized, from a hospital standpoint, both of our organizations shifted our attention, to our teams, as well as to the victims, and identifying those resources, be it through the VA. We had 2 mobile 40-foot vans that the VA brought in, staffed with psychologists, psychiatrists, social workers, crisis counselors. We flew in 5 other crisis counselors, where we provided resources for our teams as well as the victims. We had here at Sunrise, I had 5 crisis counselors here for almost 10 days, 24 hours a week, and had opportunities for staff to have either one-on-one sessions, but we also dispersed the crisis counselors up to all of our departments and floors and units to be certain we're able to talk through what many of our employees saw, and help them have resources to work through some of those challenges. As well as on one of the last slides, and I actually may try to advance the presentation backwards here for a moment. In the upper right, you'll see it was our VP of Operations at the time, surrounded by a dozen or so therapy dogs, and all of the support that we received, including the therapy dogs, were one of the most important elements in helping our patients as well as our teams work through the situation. And I would be remiss if I did not point out the support from the Country Music Association and all the folks, in Nashville and associated with country music. That industry, really assisted Mason and myself, our organizations, and the entire community in the healing process.
Yeah, and then great comments and well said, Todd. I think, and both Todd and I, our leadership style is really just a constant presence throughout the hospital, just checking on our resources, the needs of the staff, the emotional well-being. Again, no one ever complained or asked if they could take a break. Both of our hospitals came together to really provide some extraordinary care to our community with some of the best possible outcomes. But I think counseling services to all of your staff, if you do go through something like this, really encouraging employees that it's okay to utilize those resources and look out for each other. And, I think that's extremely important to be able to be mindful of. And then when you do have an event like this, there's been resiliency centers that have been available to the staff and visitors and patients, because this just it really goes on for many, many years, and having that resource with your county and the partners in the both private and public partnerships is something that typically has stood up and continues to be very active today, managing some of those lives and victims and their families as well.
And I would like to go, if I can, back to one of the other questions. And it's pretty. This is going to be a pretty small component, but I think a very important component when we look at emergency planning. And we all have our emergency, plans in place. We have pallets of water and emergency supplies that we break out in times of, mass trauma, as we all saw. One thing that we have added to our, large mass casualty kits is actually cell phone chargers, believe it or not. One of the challenges we saw that evening is the timeline that, we both shared. This event started at 10 p.m. and then went through, obviously, the early morning and, well into the next day. Many of our patients, as well as, families and loved ones who came to the facilities, what would start happening around 10 o'clock, midnight in the early morning of the following day, everybody's cell phones started going dead. And, we all went into our offices, gathered cell phone, chargers. Now with so many different connections into phones, just probably a little plug, be certain you have 100 or a couple of hundred actual chargers, as well as various charging cords, because now, even more importantly, the phones are the lifeline, that connects us all.
Thank you. Those are really insightful. Yeah, Mindy, I'll turn it back to you to wrap us up.
Oh, thanks, Ashley. That's great advice. And thank you both. Thank you both for being with us. This is not the first time that you've been so generous with your time to do a webinar with the American Hospital Association, and so we greatly appreciate all your insights. And I know your colleagues across the country who benefited greatly from the first webinar will be more than interested in how, after several years and looking back, how you've, how the thoughts that you've had about how to prepare and how to respond to all the challenges that you faced, including helping your staff through traumatic events, and helping the community, and where you can go for resources, and the kind of small and large things that really can make a difference. Whether it's rallying the community to provide blood, or making sure that you have phone chargers so that your staff can stay in contact. All of that is such terrific advice, and I know your colleagues and those around the country who are responsible for ensuring that their hospitals and hospital systems are up to the challenge. Appreciate it greatly. So let me wrap this up again for all of you who are listening to the webinar today. If you want to learn more about the National Mass Violence Victimization Resource Center, please visit their website. You can see it on the screen. You can also access it from AHA's website. You can re-review this webinar and the other webinars in this series on mass violence and register for upcoming webinars at aha.org/HAV. Again, thank you, Mason and Todd. All the best to you, and again, thank you for being so generous with your time in sharing it with your colleagues around the country to help them be more prepared for an incidence of mass violence. Thank you.
Thank you very much.
Our pleasure. Thank you.
Thank you. Ladies and gentlemen, that concludes today's presentation. You may log off your webinars, and thank you for joining us today.